how many people we've got logged on right now?
Approximately 35, 40.
Oh, how many of the board members is really?
I'll have to call roll here really quick.
Okay.
Bob Stewart here.
Here.
Good afternoon. I heard Bill Gruff.
Here.
Jeff, Tom Siltabo.
Here.
Robert Young.
Here.
Reed, Scott Schwalbach. Reed. JJ Schofield.
Here.
JJ, Susan Miller.
Here.
Susan Reike Smith, I think I heard earlier.
Yes, you did. Here.
And Bonnie.
Here.
Great, thank you so much.
All present and accounted for. Okay, with that, I will call the first meeting of 2021 of the Oregon Educators Benefit Board to order. Welcome everybody and Happy New Year. I know we're off to a stressful start for many of you, but we'll move ahead. Before the director's report, two things. One is we need to approve the minutes from the last meeting. And the other is because of some of the members are going to have to step out for a while, may make some ad hoc changes to the agenda as we go along. So I apologize for that, but at the same time, we want people to be included where possible. With that said, let's talk about the meeting minutes from the last two meetings. If everybody's had a chance to review those, any questions? Okay, entertain a motion.
Move to approve.
One or both?
Both.
There's a second. All in favor?
Aye.
Aye.
Aye. Sounds like a majority to me. Approved.
I was not at the first meeting, so I don't know if I need to abstain from that one but I did read the minutes.
So noted.
Thanks.
Yes, you were missed. Okay, Ali, we're going to add a little bit to your report ad hoc, and that is inoculations is what I'm trying to say, vaccines. But go ahead.
Okay. Well, great. Thank you, Jeff. I hope everybody had a very restful holiday season, and I'm sure, like my family, everybody else was up at the ski lodges trying to get some skiing in and finding about as busy of a place as you can imagine. Okay, so what I'd like to do is first give the board an update on the upcoming legislative session. It's going to be a virtual session, which will be obviously very different, and we'll be giving the board periodic updates of legislation impacting OEBB. We are still expecting a busy legislative session, and we've been receiving some heads up of upcoming bills. I think the bills are going to drop here in about a week or two, so we'll be providing updates to the board fairly often. So, also in early February, Jeff Brown, myself, and the PEB board chair will be presenting to the Ways and Means Committee. Will be this is something done. It's about a 45-minute to an hour presentation where we take questions and really talk about what the program has been up to, successes, challenges, short and long-term goals, and we'll be focusing a lot of the presentation, obviously, on the impact that COVID-19 has had, both financially and with our members, and care avoidance, resources for emotional wellness, behavioral health, and what we've done to respond to that. We'll also be talking about our value-based payment work in the innovation work group and with the boards, the work that CIAO's been doing in various areas. Metrics is definitely one we'll talk about. We'll talk about both PEB and OEB's alignment with the Senate Bill 889 committee, which you heard in the last board meeting, and also the focus on health equity and forming subgroups to get that work started and make sure that that work moves forward. And then just takeaways, I think, things that we've learned after going through the COVID crisis and how it may be going to impact our work going forward. And anyway, we'll provide the board with a copy of that, and obviously we'll be reporting on cost containment provisions and from the hospital cap, the payment cap, the double coverage surcharge, and of course our 3.4% cap. And then we'll also talk about our Secretary of State performance audit. So it will be an action-packed presentation. We'll actually send you the link too, so you can watch it if you'd like. Next, I'd like to just give the board a brief update on our work with the OEB stakeholder group. This is a group that I mentioned in a director's report last fall, and it comprises of a small group of colleagues from our various stakeholder groups, including OSBA, COSA, OEA, OSEA, OASBO, and then a handful of educational entities and other advisors. And the focus of the work group has been to develop a common understanding of the drivers of healthcare and insurance costs, and to really streamline communications between the board and its stakeholder groups. So to really help get our communications out to the right people at the right time, and so they can deliver the right messages to our members and other employers. OEB staff has been engaged with this group for a few months now, and working on educational materials and other focus work, which I'll talk about. OEB board leadership has also been involved in this work. So we are now close to completing our first presentation. It's titled Insurance 101, and the Deputy Director, Damian Braco, has really been leading this work with the group. And this first presentation includes fundamental concepts involved in healthcare and large group insurance, what drives healthcare costs, the value-added services and market influence provided by OEB that is unique to our extra large group and other extra large group plans, as well as just gaining a better understanding of cost containment measures that OEB has in place to moderate the trend of healthcare costs. One item that has really seemed to resonate with the work group is how the 3.4% cap is calculated according to legislative mandates. So showing in visual form, what's included in that calculation and how we arrive at that, and also the composite rate. Damian did a really nice visual showing several plans with various increases and how they work towards the overall composite rate and how that applies to the test, the 3.4% test. And then the value of having a 200% of Medicare cap on hospital costs that is unique only to PEB and OEB in the state. The plan is to record the presentation once it is finalized and post it to YouTube and distribute it to our stakeholders around the state and to members. And the next presentations will be focused on budgeting and rate development, as well as communications work. We'll provide, again, the board with periodic updates of this work and share the presentations and report back on report on feedback we receive from our stakeholders. We feel like this work aligns with the findings of the Secretary of State audit to enhance education materials and communications with our members, and will add value. So, I think that so far it's been really positive. I think it will only enhance our ability. I think Tom and Bill may talk about this later in the CIO update, but one of the biggest problems that we have are not necessarily the communications that we send out. It's getting people to read the communications and act upon them. And I really do think that having a close engagement with our stakeholders and working with them collaboratively will help us get there. So entertain any questions. That's all I have for now, Jeff. Thank you. You there, Jeff?
Sorry, I turned it on mute because the printer went off.
No problem.
So I know you've been working or participating in a COVID group, COVID strategy, et cetera. And I've heard rumors that the governor's going to elevate the position of school workers, giving them more priority for the vaccine. Is that true? And what plans are there to help school workers as they're being brought back onto the campus in a couple weeks in stages?
Yeah, I wish I had the answer to that. I don't. The governor's actually formed a vaccine distribution committee. I'm not a part of that committee.
Okay. Do either of you superintendents have any information on that?
Jeff, the only information I would have, I was at a meeting with the governor yesterday. I think it's going to be weeks or months before the vaccine is available for educators.
Oh,
So it's not anytime soon. The rollout is much slower than they anticipated it was going to be. And there's still tens of thousands within classification 1A that need to be vaccinated before they get to 1B.
okay.
And I would certainly echo where Bob is. We heard the same thing up in Washington County yesterday. And I would, as I shared with you earlier, Jeff, for us and for, I know the districts in the TriMet area, Washington, I'm looking at Washington and Multnomah that we typically run with, that vaccination is a predicate before we do anything that's whole scale and fully ramped up. Particularly if the Washington metrics are the metrics that are adopted.
This is Tom. This is Tom. I have a question. Do we know yet what percentage of school employees, teachers, and all the associated staff are going to accept the vaccine? We've seen in our nursing homes, which is 1A, a significant percentage of workers who are refusing the vaccine.
I would expect that school employees will mirror the rest of society.
Okay, is there anything as of today that you would ask the staff and board leadership to pursue on your behalf?
Yeah, I do. I think that, there would be high interest in the part of educators to what the vaccine is able to roll out, that would have some form of local destinations for where those vaccines could be administered. I think depending on what the storage requirements are of the vaccine, schools could be a natural place to administer the vaccine. But I know the Pfizer vaccine, that would be impossible. And I don't know what the storage requirements are for the other vaccines, so that may or may not be feasible and possible. I think that the other thing that we would want to explore is who can administer the vaccine, and what qualifications does that person have to have, and training do they have to have, and is there any possibility that there could be some flexibility there?
I second both of Bob's requests, and I'd like to add that it'd be great. I know it wasn't possible for this meeting, but maybe for next meeting we could have Boda and Kaiser talk about what their plans for the vaccine rollout and actually putting the vaccines in people's arms are.
I would like, Robert, I think that's great. I'd add one more. I'd like to hear from the Oregon Health Authority as to what their thinking is.
Yeah, agreed.
Yep, we can definitely do that.
Because this is Tom. I think the issue around asking Moda and Kaiser Permanente, the issue is whether or not I know Kaiser Permanente has been given vaccine for its own staff because it's a healthcare provider. The issue of where the vaccine is going, my understanding is it's still 100% under OHA. So I think OHA is going to be the dominant, it's going to be the driver of this. The other issue about using schools as places for immunizations, agreed, the Pfizer and the Moderna vaccine require ultra cold storage. The way that that's being dealt with in long-term care facilities is that it's kept in that environment, and then some entity, a lot of them have been pharmacies, the national pharmacies, have then been contracted to go out to provide the vaccine at a particular date, and the vaccine is then good for X amount of time. I think for the Pfizer, it's in the 3 to 5 day range once it's out of the 90 degrees below zero storage.
And to Tom's point, that was the conversation we had with Washington County yesterday. It was relative to using the Walgreens CVS. And in Tigard-Tualatin, we have already worked with both the cities of Tigard and the cities of Tualatin to take a look at our 2 high schools as potential drive-through vaccination sites, and do traffic studies in preparation for potential of having CVS and/or Walgreens be the deliverer.
Okay.
Yeah, I've heard the same information. Ideally, we could get a lot of people if we kind of handled it similar to a flu shot clinic that we conduct through our third-party administrator, and that's what we've talked about a little bit with the committee, but we're not sure they exist yet. So the administrator that facilitates the administration of the vaccine. So I will definitely bring somebody back from OHA as well as bring the carriers in to talk next month.
Yeah, perhaps Ali, you and I and whoever else is appropriate can engage in some conversations with our carrier partners as well as OHA so that we are keeping this moving as quickly as possible.
Yep.
Yes, Ali, this is Reed. We understand that OHA is actually meeting this Thursday of this week to talk about the vaccination schedule. So if there's any ways to do outreach to them this week, we have a lot of folks who are really anxious, and we've heard just today that NISA is going to start vaccinating teachers next week. And so we're going to start seeing a lot of angst in the state if some educators in some parts of the state are getting the vaccination and others not. So the more that we can have clear communication, and OEHA can really help people understand probably how the vaccination distribution is being decided, but then also the more we can push to move educators up in that vaccination schedule, that would be really, really helpful.
Okay.
I'm sorry, I'm having a little bit of trouble hearing you, Reed, but hopefully somebody else got that.
Well, I heard Reed, and correct me if I'm wrong, you would like any information that we come across that we can pass along to the board and who can pass it along to their members and organizations would be very helpful, and I definitely will. I'll see what I can find as far as employees of school districts and other local governments, and pass along information as we receive it.
Jeff, is this any better for audio?
A little bit.
Yeah, kind of like you're in a can to me.
Okay. One of the things that I said was that we were told that OHA is meeting this Thursday to talk about the vaccination schedule. So outreach this week would be timely.
Okay. So has everybody who's spoken, do you have a sense that your concerns were acknowledged? I just want to double check since we're in this funny meeting platform. Are we good to move? I'm not getting any feedback. Yes?
Yeah, this is Tom. Just a comment. We've known that vaccines are coming, and the fact that we're starting to think about what we're going to do with it is more than a little surprising to me. That's an editorial comment. I can use other words, but I'll just use it. I'll just say that.
Yes. Yeah, the wheels are definitely in motion. Unfortunately, there's not a lot of details. You know,
and the wheels should have been in motion about 4 months ago.
Yeah, that's right.
Well, we need to focus on what comes next.
Yes, I agree.
Yeah.
So,
Sounds good.
okay. Anything else before we move to the next subject?
No, sir.
Okay, let's move to the rulemaking. April?
There we go. Is my mic on? Can you guys hear me?
Yes.
Mic, but not camera.
Okay, I think it might be my internet connection. It went down like 5 minutes ago, so I apologize. Well, shoot, I was hoping you could see my face because it's nice to see other faces, right?
Yep.
So this is April Kelly. You've probably seen or heard from me before. I am the OEB and PEB rules coordinator. So I'll be talking about page 8 and 9 in your PDF packet. And before I get started, I wanted to sincerely apologize. The rule number on the agenda and the rule number on the attachment, on attachment 2, is not correct. And the only reason that I can come up with is that I was multitasking with rules and I just completely botched this one. So the correct chapter is 111, Division 40, Rule 0055. So I just wanted you guys to take note of that, and then hopefully we can get this corrected in the minutes for this meeting. So I sincerely apologize for that. However, the content is the same. It is about the surcharge rule. You saw this back in October when I requested that I file this rule as a temporary rule because we were a little past the October 1st effective date, and then move into the permanent rulemaking process, which we did. We held a rule hearing on November 19th. Our public comment period was the whole month of November that ended on November 30th. We did receive a public comment from a teacher who is married to a public employee and believed that the rule had unfairly targeted couples who dedicated their careers to serving the public. And I completely sympathized. And then I did reply and let her know that this came out of legislation, and when legislation gets passed and we get directed to implement, then that's what we were doing. And we used the rule to explain the statute. But other than that, I don't think I have anything else in my notes. The language didn't change from its current form, its current temporary form. So I'm asking for approval to file permanent, and in filing permanent, I will repeal the temporary rule, and then the surcharge rule will become a permanent rule with Secretary of State.
Okay. Any questions of April? Any clarifications needed? Do I have a motion?
This is JJ.
So moved.
I move to approve the rule to permanent status.
I'll second.
Second.
Okay, all in favor?
Aye.
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 Motion's passed. Well, I guess I should say any opposed.
Yes, this is Reed. I oppose.
Okay. Thank you. Motion carries though.
Great. Thank you so much.
Okay. Let's see, how many of you have to leave it just before 2? Susan and Reed and anybody else?
Bob.
Bob, okay, thank you. Next up is, as we're now entering the renewal planning and execution season, our consultants with their renewal considerations. Jenny?
Hello, Happy New Year to everybody. It is good to see many of your faces. So, and it sounds like the board is certainly hitting the ground running on this second day of the year with a lot of considerations already to be thinking about. But as Jeff said, we're starting to think about the upcoming renewal season as we typically do in January. So the purpose of today's presentation is to talk about sort of the concepts that will be prominent in the renewal this season in the spring, as well as, you know, what are the kinds of things that we suggest that the board consider or be thinking about either in the short term or the long term to impact cost, quality, and of course, access. So let's see if we go to the next slide. I should actually just pause and make sure that Brad Lawson is also on the call. I think he is.
I sure am. As
Okay.
soon as I find my mute button.
Good for me to know if I jump in and cover your slides too. But so Brad, I will have him kind of talk a little bit about, so after I talk about the goals and the some of the legislative things to be thinking about, Brad is going to talk with you a little bit about how the OEB plans are performing, what the trends are looking like, and how COVID has impacted those. We've prepared for you an illustrative renewal scenario showing what the impact of last year's decisions may have on the upcoming renewal, just to get your sort of as a teaser to get your mind thinking about how you all will need to approach the upcoming renewal. And then we'll talk a little bit about, you know, cost drivers and how to make an impact on future cost and quality. And those are, if you've already previewed these slides, you'll notice that some of these are very familiar to you all. And then we'll end up by talking a little bit about the innovation work group initiatives that are being considered. All right, let's go to the next slide. All right, so the goals and objectives for the upcoming renewal are very similar to the ones that we identified last year in the renewal process. So continuing to make sure that the rates are competitive, sustainable, and appropriate for each plan design is a good priority. Continuing to ensure that members have a meaningful choice of plan designs, and we'll probably come back and talk a little bit about that concept more towards the end of our talk today. Continuing to consider ideas that and innovations that improve the efficiency of the program, and we'll talk more about that. Of course, leading the legislative requirement of not more than 3.4% growth is something we all know about. And we're going to talk a little bit about some of the legislative considerations that will impact the future of the program. And then sort of a new, not new, but something that we're overtly listing here on goals is understanding and addressing the diverse needs of the membership. All right. So this year, we usually do a quick overview of any recent federal legislative changes that may impact the upcoming renewal. And so we've listed a few things here pertaining to a recent law that was signed at the very end of 2020 that included a number of things, but 3 or 4 things that will eventually need to be incorporated into OEB programs. And that is some provisions to end surprise medical billing. So, those are for when members go out of network, but they didn't necessarily choose to go to that out-of-network provider. And that includes things like anesthesiologists, lab providers, that kind of thing. There are some temporary flexibilities for health and dependent care spending accounts. So that's FSAs and dependent care FSAs in the upcoming year. And then some new transparency in healthcare cost legislation that will include some new disclosure requirements for group health plans. And most of these things, with the exception of the spending account deal, are really going to be effective in not this upcoming renewal, but the following, so in 2022. But some of the ones, for example, the transparency, are a bit robust, and so it may take some time to kind of implement. So we usually talk at this point about whether or not there's changes to taxes and fees. And at this point, there's no changes to future taxes and fees. There's going to be just a little bit of an impact to the upcoming renewal in a favorable way for members, bringing some of the rates down just a little bit for some from some tax that was in the previous year's costs. But nothing significant so far. Of course, I think Ali did mention that the legislative session is just getting going, and so we never know if there are any new mandates or provisions that will impact the upcoming plan year program. And then, of course, noted here is the vaccine is going to be covered and classified as preventive, so covered at 100%. So that's good news. Okay, we can go to the next slide. Okay, so at this point, I'm going to turn this over to Brad, and he's going to talk a bit about the plan performance.
Yeah, so we like to take a pause once in a while and take a broad view of how we think the plans are running. We're going to take a look at the MODA medical prescription drug and also the dental plan, and do the same for Kaiser. Certainly when we look at plan performance and start thinking about it, one of the first things that comes to mind is how COVID has made this a very challenging thing to do. Certainly during the pandemic, we saw a lot of claim suppression, and that really is masking how the plan may be performing. But at the same time, eventually that is the plan experience, and we do want to look at it and see how things are going. So we've done a little bit of a combination approach for the current board meeting. We've taken a look at we've kind of provided 4 years of claims data that we have in there, and we've kind of just taken a look and say, if we look at all 4 of those years together, and we look at the ups and the downs and all that stuff and everything that's been happening, how has our cash out the door picture been? And we do this basically on the funding report, so it's really just a paid basis. We don't try and do a lot of adjustments for different events that may have happened. This is really just looking at how the plan has been performing over those 4 years. But we also wanted to take a pause and step back and say, well, the pandemic certainly had a big impact, and we'll see that especially on the dental plans, and really bent that trend a lot. So what would trend look like if we just looked at the 36 months before COVID had hit? How were we doing at that point? And we defined that period as anything, the 36 months ending with February 2020. So you can see here, generally the plan has been running pretty favorably. You could laugh, I looked at 60 different trend measures for this, and they're all running pretty much flat to the low single digits, no matter how you look at it. And that's a really, really good news. It's a really good picture. If we just take the full 4 years, we can see that line toward the right-hand side of that chart. And just to the right of that, we can see the pandemic impact, that claim suppression in the first few months there. And then we see the bounce back starting in July and kind of more back to our regular ups and downs pattern. With that, we're at about 1.7% all in. And then if we look at the 36 months prior to that, where it was really fairly flat. So just good news on that. We have a couple little pieces. If we look at medical, was just a hair over 1%, and RX is performing very well at a little bit under 5%. And I do want to just take a quick note and say the RX, when we look at it, really was not impacted by the pandemic. So we didn't have the same kind of claim suppression on the RX side as the medical. So, looking
Brad,
at that 4.8 number is very real and encouraging. Mm-hmm.
Brad, is this paid or incurred, or does that make any difference?
I looked at it all different ways. This is just a paid. So the way that I like to look at plan performance, at the end of the day, is cash out the door. And so this is on a paid basis. So it's not allowed claims. It's not on an incurred basis. This is just cash out the door. When we did look at the incurred claims and allowed, we're still running, between, 0.5 to 2%. So very, very consistent trend measures from the plan performance perspective on that. Good question.
So
Any
maybe
other?
I was going to say the only other item to maybe note on here, right, is that so before the pandemic hit, in October, about a year ago, that's when the hospital reimbursement cap took effect, and so we did expect that actual paid claims would be dampened a bit. So some of that was expected, and then of course we have COVID that kind of scrambled everything.
Yep. Absolutely. All right. Thank you for the comment, Jenny. Any other questions before we take a quick look at dental? All right. So we can see dental had a very similar effect from the pandemic. You see our plunge to the right of the vertical line there. It's certainly the pandemic impact, and we can see the bounce back again starting in about July, where claims are starting to return more to normal levels. But that sharp decline caused our long-term trend, our 48-month trend, to drop to about -3.5. So when we went back and looked at some other pictures, more of a pre-pandemic look, the plan has been running closer to about 4%, right around there over the last 3 years. Any questions? All right, I think we can move to the next slide. So here we have the combined medical prescription drug for Kaiser. Kaiser, similar story. Really, no matter how we looked at it, the plan's been performing, very well with the limited volatility. And we've been running right around just a little bit under, just a little in the negative territory. So including the pandemic, we're at about -0.5%, and the period before the pandemic, the 3 years, were running at about -0.3%. And we can see that in this case, the RX trend has actually been lower than the medical trend. So, and again, thinking that RX, that 48-month RX trend really was not pandemic impacted. So that -3.1% there that we see in the bullet point is really a strong indicator of real plan performance on the RX side. Right. Any questions? And we'll take a quick look at Kaiser's dental experience. So here we see that a very sharp decline from the pandemic, not having recovered quite up to the normal levels. And that is causing us to have a massive long-term, trend of -18%. If we back up and look at our pre-pandemic, we're also running very, very low at -5%. a good part of that is, being driven by introduction in October 2018 of some significant cost sharing. You can kind of see in the middle of the chart, kind of right around that period, we do have a drop after September 18. We do drop down and sort of adjust to a new level. So looking at that new level, it's not a tremendous amount of experience, but it is largely flat, versus the negative there. So, but in general, very strong plan performance from the Kaiser Dental program. All right, we can move to the next slide. All right, so we've got a couple of examples just to start the thinking process about how the RSR and the use of the RSR can impact our rate increases in the, both the current and the following year. So as a quick refresher, and this is an illustrative scenario for MODA, last year we had the base renewal came in right about 5.6%, and we elected to use some RSR funds to buy down that rate increase by about 1%. And so we can kind of see on our bars, if we sort of think that that first bar is the 1920 plan cost and we had a 5.6% increase, we should have been at the top of the blue bar in the middle there. And instead we ended up kind of at the top of the purple bar, which was a smaller change. And if we assume that our renewal comes in at a 3.4%, which is our target, if that were to happen, and we had not decreased with the RSR and we were at the appropriate top of the 2020-2021 bar, we would have had an increase of about, of course, 3.4%. But because we're starting at the bottom of the blue section, our rates were a little lower than they should have been. It takes a little bit more increase to get back up to the 21-22 expected costs. And right now we're expecting that to increase our renewal by about an extra 1%. There's some rounding and some leveraging and all kinds of fun stuff, but the general sort of lesson is we bought it down last year by about 1%, and we're going to need about an extra % now to recover. And it's a good time to take a quick pause and talk about the use of the RSR maybe just for a brief moment. And as a reminder, the use of this RSR is very, very good when we have renewals that are fluctuating around our target. For example, our target of 3.4, we had a renewal last year that came in higher than that, and we used the RSR to buy down. If our renewal comes in lower than 3.4 next year, that's great. And we have that impact, that leveraging will buy it back up closer to our target. If we don't do that, if we just continue to have higher than target increases, then we are going to see leveraged increases each time that we use that RSR as a buy down. So any questions on that?
Well, I think the implications are going to become more clear over the next couple meetings.
Yes. Yep. So the following slide really illustrates the reverse of that. And this is sort of what happened with the Kaiser plan. Recall last year, the renewal, kind of the base renewal came in at about -5%. And the board chose to take about half of that as a decrease of about 2.5%. And the difference was added to the RSR. So in this case, if we look at sort of our illustrative scenario here, we started out with the 1920 bar being higher than the real plan cost of the 2021, and the plan cost being sort of at the bottom of the blue bar. And we bought those rates up. And you can kind of see the RSR sort of added on to the plan cost to make our rates higher than they really needed to be. And so as we start thinking about the 21-22 renewal, if we have a 3.4 target increase, rather than going from a plan cost to plan cost and seeing that 3.4, we're actually starting at a higher rate, and we need a lot less of an increase to get to our new expected plan cost of 21-22. So if we were to have a 3.4% increase for the 21-22 claims, we would really only need a rate increase of about 0.7%. So we see sort of the opposite leveraging effect in this example. Any questions on that?
Brad, this is Tom. And with what you just talked about, that doesn't change what that fund is. So like in this situation, I'm looking at the Kaiser example. The fact that there still is money in that fund, it doesn't change that amount of money in the fund.
Correct. Yeah. In
and the
neither
same thing
of
would be
these.
the MODA. Okay, got it. Thank you.
Yep.
Yeah.
Yep. Yeah. In 2021 plan year, we added to the RSR for Kaiser and decreased the RSR for MODA. So MODA's 2021 renewal used some of the RSR, and Kaiser's added to it in the management there. And we'll kind of see that if we move to the next slide. We have just a brief projection of what we think the RSR balances are going to be in the absence of any further actions as a result of those renewals decisions. Recall that Kaiser came in at about 10.8 million in October of 2020, and in October 2021 we expect that to grow by just a hair over $5 million because of that that rate increase that we had. So we banked that into the RSR. Or on the MODA side, we ended in October 2020 with about 30.8 million, and that will go down by just about 5 million to 26.1 million in there. And of course, those numbers are just projections that could certainly change with enrollment and other things that may come up. Any other questions on that? If not, we can turn it back over to Jenny.
Okay. So, we talked a little bit about trend and, the stabilization funds. I think the one thing before we kind of get into these cost driver ideas is just a quick update to let you know that so next month at February, we will be coming back to you with preliminary renewal positions for all the carriers. So the medical, dental, vision, and all the others, along with some, ideas for plan changes or program changes that we have asked the carriers to think about in the renewal process. So, but as we're, thinking about, it's kind of hard to talk about this before you know what the starting level of the renewal is, but just knowing that each year it's helpful to make changes or consider ideas or programs that are going to continually improve the cost, the access, the quality, the outcomes of the program, to make sure that we continue on with the good experience that OEB has been seeing of late. So you'll remember this slide. It's I think it's familiar to most of you. When we think about what are the kinds of areas that truly impact healthcare cost, or what are the cost drivers of a healthcare plan, an employer-provided healthcare plan, we tend to bucket them into three main categories. And the first one is the purple, which is the covered population. So, who you have covered and how many people you have covered and how old they are and how healthy or sick they are really does have an impact on, OEB's costs, for instance, versus another large plan sponsor. Of those things that I just mentioned in the purple section, really the covered spouses and dependents is probably the biggest driver of overall healthcare costs. And we'll talk a little bit more about that next. But And we've talked a little bit about that before too in implementing something like the double coverage surcharge. So we'll talk a little bit more about that. The second area that we talk about is, the value of the plan designs that are offered. So the deductibles, co-payments, cost sharing elements, and how the employer in this instance shares those costs with employees through payroll deductions, HSA seating, HRA funding, if that's something that's in place. And I guess the idea here is that, OEB, of course, makes a variety of different plans available. But ultimately, the members select which plan they're in, and that has a lot to do with how much their employer subsidizes that particular plan and whether or not they're sort of encouraging through those payroll deductions or HSA funding employees to select one plan over another. We'll talk more about that in the upcoming slide. And then the green area, which is that program efficiency, that's of course where OEB and CIO and the innovation work group spend quite a bit of time talking, because I think I've mentioned this before, if you want to keep covering the same people and you want to keep offering relatively similar plan designs, the area that you have that you need to focus on the most is that list on the right-hand side. So how people use healthcare services, how often do they go to the doctor? How often do they go to the hospital? That's utilization. And the other big lever is unit cost. How much do those services increase in cost year to year? And then we take a look at pharmacy, but really it's the same flavor of those two ideas. How much do the prescriptions cost each year and how much does that increase? And how many people are taking prescriptions and are they taking more or fewer year to year? And then the last pillar on this slide has to do with the effectiveness of the vendor and carrier partnerships. So, if the carriers have really great medical management programs or coordinated care programs, that really does impact the overall utilization of the program. Okay, so we're going to dive briefly into these three areas a little bit further. Our overall kind of question in each one of these areas is how much influence does OEB have in this area? So talked about covered population. At the end of the day, OEB or the legislature through the rules makes the determination about who's really eligible to participate in the OEB program and who is an eligible dependent, right? But at the end of the day, the entities really are the driver of who's ultimately covered by how many people they hire, how they structure their contributions to either encourage spouses to enroll or not enroll. So you'll see on each one of these areas of focus, we put forward a couple of different suggestions. So if you really wanted to make a program change to impact the covered population, we just listed a few ideas for you. And here you can kind of see a couple of ideas that have been floated around in the past. The first is, well, if you have retirees on the program and their health care consumption is typically more than an active employee, does it make sense to apply some sort of a higher cost factor to that population to accurately reflect the cost of their care? And that's an interesting idea to consider, although it's not going to have a huge impact on the overall OEB cost because retirees are about 10% of the population. So you can only do that so much to help, shift the cost sharing between active employees and retirees. And at the end of the day, all of those costs are in the OEB program. So if we're looking at a 3.4% overall cost growth, both of them are in there, regardless of who's paying a little bit more or less. And then the second idea, many employers have considered and implemented what's called a working spouse surcharge. So What that means is, if you have an OEB employee and a spouse has access to other coverage, perhaps outside of OEB, do you impose some sort of a surcharge for them to stay on the OEB program? And again, many employers have implemented that kind of an idea. We've noted here that it may work best at the entity level rather than at the OEB level, because typically a spousal surcharge like this works in conjunction with your premium contribution strategy. And those are actually not all, those are determined for the most part at OEB at the entity or employer group level. Any questions about these? No. All right. So the second area of our wheel has to do with the plan design and cost sharing. So, OEB has most primary influence over, what plans are offered and what carriers are offered. And, as you all know, or most of you know, we have spent a fair amount of time making sure that we have appropriate plan designs that are rated correctly, and have even done an RFP to ensure that the carrier choices are still the right choices for OEB. But at the end of the day, entities also have some influence in this area of the wheel, as I mentioned before, just through how they structure their premium cost sharing. So if a particular entity really funds their program so that the member has no cost sharing to enroll in the richest plan design, most members will do that, even if they don't necessarily need that richer plan design. And then on the other end of the spectrum, if the entity or employer really sets their funding at the highest deductible plan and the lowest cost, we have found that a lot of members will, work towards moving to that program over time. And so that's how, it ends up impacting your costs overall, but doesn't really something that OEB has influence over. Okay, so here we just listed a few ideas that OEB has considered and reviewed over the last few years. Nothing new here, but certainly something that we can continue to think about. Any questions here, or anybody want to talk about any of these items here? Okay. Okay, so on the left, we want to go to the next slide. Okay, so here we've listed a number of things under program efficiency. And again, this is the area where OEB has the most influence in terms of plan design. So we've listed things here such as, advancing levels of value-based payments. You've heard of that before. And certainly something we're focused on. Perhaps expanding the Medicare reimbursement cap to things that are outside of the hospital. So provider, outpatient things. Narrow networks. So narrow networks, or what we might call them as high performance networks. So many employers have been working to try to identify those providers that are coordinating care better or performing better, and trying to steer their members to those providers. Excuse me. I'm just gonna. And then, so I think this is, perhaps an area where OEB may want to consider in the future, focusing more effort on the PCP 360 providers. Not sure if it's necessarily something to be executed this year, but we may want to take a look at that. Certainly, it's helpful to have a broad range of providers for members to choose from. And that's great, but sometimes that comes at a cost. And so if we can show that using the PCP 360 providers are going to result in lower costs, does it make sense to continue to offer that broad network? Certainly an interesting thing to think about in the future. Digital healthcare solutions, we talked about that last month. So many members are now comfortable with getting their healthcare online or, through a virtual setting. And in some cases, not all, but in some cases, those services are either lower cost or can help provide better access by, just being more available. So it makes sense to perhaps seize the opportunity to expand those types of solutions. Vendor point solutions. So typically they're third-party solutions, but sometimes carriers will contract with them, like Omada that MODA put forth this year, and like Maru, and then for Kaiser, kind of like MyStrength. So there may be some good niche specialty providers that can help provide, more robust care management and support for members. That really makes sense to consider. I kind of mentioned the steerage to high quality providers. That really does go hand in hand, usually with the narrow network. And then pharmacy steerage programs. And it's kind of interesting when we look at these, this list. I hadn't seen MODA's presentation. They'll talk to you in just a little bit, but we have many of the same ideas. So that's good. Okay. So on the next page, yeah. So Jeff kind of asked our firm to come up with, we just hit you with quite a few ideas or things to consider or areas to explore. And he said, what are the things that you recommend specific for OEB over the next year or two as priorities? And so on this page, we've listed sort of our point of view on where you might want to focus your attention in the next year. So the digital health solutions, excuse me, the pharmacy steerage programs, and the narrow networks. We did list the increasing the deductibles and out-of-pockets, cost sharing every 3 years. We have kind of gotten to a good level about 2 years ago. So not at this coming renewal, but we think at the following year, it might be a good time to make sure that those are at the right levels. And then finally, Brad touched on this a little bit earlier, but the use of the RSR funds, can be helpful to mitigate some increases or even lower than necessary areas to kind of smooth over whether or not you're close to the 3.4%. But it's also perhaps a good idea to think about investing the RSR funds into the carrier programs or ideas that will over time help lower the overall paid claims amount. So for instance, if there is a program like another program like Omada, or if there's another program like Maru or like that you want to spend the money on that program if there's an administrative cost to it, but if it's going to show some ROI over a longer period of time, those are the kinds of things that would be good to invest in. Or, I think for some of you heard about some of the wellness and resiliency programs that Kaiser and MODA are going to be proposing in the renewal. We heard about that in the CL meeting this morning. So that's another good area to perhaps invest some of the RSR funds. So before we move on, are there any questions about this or anything you want to, discuss?
Yeah, hi, it's Robert. Sorry, I'm getting a little reverb. Back on page 13, could you talk a little bit more about the working spouse surcharge?
Mm-hmm. Yeah, so a working spouse surcharge works like this. If let's just say, you have an OEB employee and they have a spouse who works for PGE, if OEB were to implement a working spouse surcharge, they would say, if you if your spouse has access to that PGE coverage, but you elect to stay on the OEB program, we're going to surcharge you an additional, $50 or $100 or whatever it would be per month that you're on the plan. So it works a little bit similar to that double coverage surcharge, but it's very specific to spouses who have other coverage but elect to stay on OEB. And I'm kind of glad you brought that up because it's definitely an idea that many plan sponsors have implemented over the year because, and not every employer is this way, but an employer might have a value proposition in their business that says, we want to offer medical coverage primarily for our employees. And yes, we want to make it available to family members, but as a business, our priority is to our employees, right? Not all employers are like that. A lot of employers do have a very robust plan subsidy for all family members, but that's just, one tactic. And so if you think we want to offer that program for our employees, but we'd kind of like to encourage them to go get their own healthcare coverage at their own employers, that's what's behind a working spouse surcharge. But what I put on that slide 13 is that, OEB, the idea of OEB is to aggregate everybody under the same tent, right? Under the same plan tent. Because if everybody is under the same program together, there's a lot of purchasing power with the carriers, and there's a lot of leverage with the provider community to make significant changes like value-based payment arrangements and coordinated care. So it's certainly a concept to consider. It's very much cost savings driven, but it just hasn't been the focus for OEB.
And I would just add that PEB actually has a special surcharge. It's $50 a month. They've had it for about 5-6 years now.
Yeah. Does that help answer the?
Yeah. So so with this, since we there was legislation that set the double coverage that we now impose, are you envisioning this as being an additional surcharge?
So it's on the slide as something to consider. I think we weren't necessarily recommending moving forward with all of.
Yeah, I overstated.
Yeah, the ones here, but you can certainly tell us that you'd like to consider that. We can price it for you.
Okay, thanks.
Jenny, appreciate you putting together this list. As I look at it, in the early stages of OEB, trying to steer people towards participating pharmacies was an initial hurdle we had to get over. So when we talk about additional steerage, we would need to have a good review of any barriers to that or access issues, just for due diligence. Same thing would go with narrow networks, because we really need to make sure that our outer lying areas would have appropriate access as well. Mm-hmm. The concept is great. We just need to make sure that we, have addressed things and have good backstory to it.
Mm-hmm. Agreed.
Couple more pages.
Okay. So lastly, I just thought I'd let you know what's happening with projects in the innovation work group. So we began meeting again after a long break over the summer, and we've picked up our work in continuing to explore the idea of centers of excellence. So if you remember, a center of excellence, and in particular, we're looking at centers of excellence for musculoskeletal conditions. So, you know, like a knee replacement, for example. So a center of excellence, a formal program typically is something like, hey, if we send all of our members who need a knee replacement to one designated facility in Oregon, or it could be outside of Oregon, who have met some very high quality metrics and who have promised a certain level of quality by means of fewer complications, fewer readmissions, and that kind of thing. That's what a center of excellence is. And the carriers have some level of that for different types of services, like transplants, for example, or bariatric surgery or something like that. So at this point, what we're doing is a formal request for information to some selected Center of Excellence vendors. And that went out in December. And we're currently evaluating the responses and plan to provide an overview of the responses at the January Innovation Work Group. And I just want to stress that this is not a request for proposal. It's really a request for information. So we're looking to understand, how does the vendor pick the facilities and providers? What quality metrics do they use? How do they guarantee results? What kind of payment mechanisms do they have, like bundled payments or warranties? And then when we present this information to the Innovation Work Group, they will have, they can decide what to do next. Either there may be enough interest to say, yeah, that sounds great. OEBB and PEB might want to move forward with a more formal RFP process, or there may be things that the Innovation Work Group members say, that sounds great. I wonder how we could make that work in the programs that we already have if we just tweak them or improve them, the programs already in place with carriers. Or, you know, there's a couple of other avenues to take. So just wanted to mention that that's not an RFP. It's simply a crowdsourcing type of an exercise. And then the Lodestar that I think James presented last month. So there is a formal request for information also planned for 2021, and that will, the idea is to send that out to various third-party administrators or carriers and understand their ability to administer the program that that is the Lodestar. And the other programs or the other ideas that we're reporting that's happening in the Innovation Work Group is just the reviewing of the impact of the hospital reimbursement cap on utilization and cost, and then just continuing to monitor the value-based payment arrangements. And I think that I got everything, but Margaret's the best person to address this page too. So there you go. That's what's happening. As I mentioned, we'll come back to you next month with the preliminary renewal positions and a few of these ideas to consider. That's what I've got. Do you have any other questions for me?
Thanks for putting this together, Jenny. Brad.
Okay.
All right.
Good, thank you.
You're welcome.
Let's see, did we lose Reed already, or does Reed leave at 3?
No, I leave at 2:30, Jeff.
2:30, okay.
And then I'm back at 3:30.
So why don't we go ahead and get Moda's presentation in, and that way we phase our break in over part of your absence. Okay, let's do that.
Great. Well, thank you, Jeff. Thanks for giving us the opportunity to speak today. We're going to be talking to you about some strategies that we'll be proposing for the upcoming plan year to help stay within that 3.4% budget. And we'll also be providing an update on some pharmacy programs that we've implemented recently that are also helping to control costs and help us meet that 3.4% target. But first, before we start any of that, I want to introduce you to our new Chief Medical Officer, Dr. Robin Singh. We're really excited to have him on our team, and we're really excited for you guys to all get to know him a little bit better. But I'm going to let him introduce himself. So, Dr. Singh.
Thank you, Erica, for the kind introduction. Good afternoon. My name is Robin Singh. I'm the Chief Medical Officer for MODA. It is a pleasure to meet you all. I've served as an executive leader in major health systems, health plans, and medical groups for a number of years, including in the academic and community settings, with success in improving outcomes, quality of care, and member experience. Deeply committed to improving the health and well-being of all Oregonians, and I'm proud to be of service to you and our members. Thank you, and I'd like to present some of the strategies towards the 3.4% target.
Welcome aboard.
Thank you. Pleasure to be here. Looking at the musculoskeletal program, so at a recent innovation work group meeting, Willis Towers Watson presented a framework for a musculoskeletal program that includes 3 major buckets: prevention, steerage, decision support, and then surgery support. While we are executing in several of these areas, including this framework, there are many areas of opportunity which we are keen to expand and where we are excited to enhance our offerings. Looking at the musculoskeletal program in more detail, prevention. One goal of MODA 360 is to increase engagement in program offerings available to OEBB members. Our health navigators help connect members to the programs and resources that are right for them. Additionally, to enhance our approach to prevention, our wellness advisors will begin offering ergonomic assessments for our entities. There are different ways we support steerage and decision support. To further enhance this focus, we're looking to partner with a vendor to provide virtual physical therapy in addition to in-person care. I'll talk more about that on the next slide. Regarding surgery support, this is consistent with our desire to build a more robust Centers of Excellence program. We strongly welcome the RFI released by Willis Towers Watson and have responded positively to this. We currently have a highly effective comprehensive delivery network and are keen to further develop analytics and assessment of this network, along with setting standards and ensuring certification of those standards, ultimately with steerage of members to the most clinically and cost-effective centers. We're looking forward to presenting this and discussing our response further with you all at the Innovation Workgroup meeting. Moving on to virtual physical therapy in more detail. We're undertaking assessment comprehensively currently of 5 vendors in this area. This is a newly emerging area that's been enabled due to recent improvements in technology and demand from consumers for virtual care. These are highly scalable solutions with a combination of, in some cases, automated physical therapy, as well as that supported by healthcare professionals. This will not completely replace all in-person PT, but will be a strong addition to the availability and delivery of physical therapy. Potential benefits include personalized programs that are evidence-based with a high degree of self-management, the convenience to have that in the workplace, at home, at night, at any time really, could also enhance adherence and allow earlier and ongoing intervention when face-to-face appointments are not practical, particularly, of course, now, but this ultimately post-COVID could also be a significant improvement in standard of care. Wide range of conditions would be applicable: acute and chronic skeleton pain, soft tissue, joint conditions, pre and post-surgical. And moving on to chronic kidney disease management as another major area of opportunity. About 650 OEB members have CKD. The annual spending for these members is about $20 million, and the average PMPM from $2,000 heading up to $6,000 per member per month. And of course, for those on dialysis, the cost then goes up dramatically further. More importantly, the human cost associated with this is very high. Mortality rates are still between 15 and 20% for those on dialysis, and the 5-year survival rate is under 50%. Substantial economic impacts also exist at the individual level. If you have to attend 4-hour dialysis sessions several times per week, it's harder to maintain employment, for example. So looking at the management of chronic kidney disease, we're evaluating multiple vendors in this area as well, and we're looking at vendors specifically that partner with the PCP earlier on and work directly with the member at a very early stage. There would be utilization of predictive analytics to identify members who will benefit from earlier intervention. The interventions aim to slow progression of CKD stages, to aid with healthy decision making, and to aid with education on treatment modalities, which can get quite complex. Home dialysis, for example, is often a better option than in-center dialysis, and that one can do home hemodialysis, not just home peritoneal dialysis. So really getting that type of understanding and education early on. This will also include ongoing treatment support, which could help to reduce unplanned admissions, readmissions, and improve outcomes. A multidisciplinary team approach is going to be essential. Social workers, dietitians, educators, clinicians in conjunction with the PCPs and nephrologists. To leave you with some national statistics, 90% of patients with stages 1 to 3 of CKD are not even aware they have it. 2/3 of patients don't know in detail about the treatment options that exist for them, including options like a transplant and home dialysis, which we just discussed. 88% of ESRD patients end up on in-center dialysis. In most cases, home is an option for them. 80% of patients transition to ESRD by crashing into dialysis at the hospital and often end out with a central venous catheter. These are situations that result in a worser outcome than is otherwise possible. There is therefore certainly a lot of opportunity in this area to serve members better. We're excited to do that. Thank you for your time.
Thank you.
Thanks, Dr. Singh.
Hi. Go ahead, Erica.
Oh, thank you, Katie. The weird virtual transitions. Katie's now going to talk to us about some innovations in the pharmacy program.
Thank you, Erica. So as many of you know, I'm Katie Sheeler. I'm a pharmacist by training and the Senior Clinical Program Manager with MODA. We wanted to just highlight a few select pharmacy programs that were implemented to keep the overall trend under the 3.4%. So though we're going to go through the site of care, high performance, formulary, and the pharmacy benefit optimization program, I want to remind everyone that we're not going to go through all of the other multiple programs that are in place and have been in place for OEB and the members for many, many years that help to decrease the upward pressures of the trend. Specialty management, high cost generics, smart wins, all of those are still operating, and we still have a lot of resources dedicated to these areas. And then lastly, we'll talk about the future programs. So if we want to move through the next slide to slide number 10, which is page 38 of the packet. So the site of care program was launched for OEB in October of 2017 in response to data analysis showing that specialty infusion drugs cost double in the hospital outpatient setting compared to provider office or home infusions.
And then we saw administration costs associated with these medications being administered in the hospital were double to quadruple the cost. So through the prior authorization, the program steers members receiving select infused specialty medications to a cost-effective infusion site, such as the home or provider office. And while this program aims to reduce costs, it's of utmost important that we're steering to sites that are clinically appropriate. And if there are none available, exception processes come into play for members. So since program inception through the end of Q3 in 2020, the site of care program has realized a total savings of $3.7 million for OEBB. Of note, as the program was implemented, providers became more familiar with the program, and so we've seen proactive initiation of therapy in the lower sites of care, which has been great. We will continue to evaluate the program and assess the expansion into other products, which I'll touch upon in the later portion of the slide. Moving to slide number 11, we'll review the high performance formulary. And as you know, this new formulary was implemented October 1st, 2018, again in direct response to Senate Bill, I said 106, that's not the right Senate Bill. My apologies, 1068. The high performance formulary works by limiting spending on the low value drugs that have less costly but equally safe and effective alternatives. The goal, if you recall, is to realize a one-time cost savings of shifting to high value medications. And now that the formulary is in place, it protects from members starting on low value products. So this led to a positive effect on our generic dispensing rate and saw a large shift from the low value drugs to high value drugs like generic medications or certain preferred brands. The savings realized for the 2018-2019 plan year was 5.9% savings on the pharmacy trend and a 1.2% savings on overall trend. And this was relative to the pre-implementation experience of the 2017-2018 plan year. During this time, we saw a $4 per member per month in cost avoidance by maximizing the use of the high value medications. Please note, as you'll see at the bottom, our analysis excluded one claim for a high-risk member in the 2018-2019 period who is on an orphan medication that's approximately $1 million per year drug. And it skewed the measurement results and was not affected by the high performance formulary, and so that particular member was excluded from this analysis. But the high performance formulary performed as expected. It's greatly slowed the trend and bent the cost curve by changing the market basket to less expensive medications that are safe and efficacious. On the next slide, you'll see another strategy created to manage costs of provider administered medications, the Pharmacy Benefit Optimization Program. It went live in October of 2019, and it shifts coverage of certain provider administered specialty medications to pay under the pharmacy benefit. As previously noted, these infused medications are typically billed through the medical benefit and have significant variability in reimbursement methodology and cost, but medications billed through the pharmacy benefits have fixed reimbursement methodology and therefore can yield savings on the drug cost alone. So we always are evaluating this program to potentially add new drugs or even remove them. We have 5 currently on the program, and with those 5, we've seen approximately $2.1 million of savings since program inception through the Q3 of 2020. And for our last few minutes, I want to touch upon future programs. Certainly, we're always looking ahead at the market and pipeline, so we're on the ball to develop new strategies aimed at reducing trend. And the first is provider-administered oncology medications. We know that these cost and utilization trends are increasing rapidly, and we're seeing oncology medications scoped into site of care programs across the country. Effective January 1st of this year, 2021, the majority of MODA business, including OEBB, added supportive oncology medications into our current site of care programs. For many patients, home infusion provides a convenient option for care, especially with supportive oncology therapies that are often dosed on different days than the chemotherapy themselves. As a reminder, supportive oncology are medications that generally treat or prevent side effects that people experience with therapeutic oncology drugs. Therapeutic oncology medications targets and treat the cancer themselves. So as a second phase, later on this year, we'll be evaluating potentially expanding the program to include these therapeutic oncology medications. But for right now, we've just scoped in the supportive oncology. But when we looked at therapeutic oncology, we're going to look to focus on single drug regimens in order to avoid complexity and the coordination of a multi-drug therapy combination. We're going to avoid drugs that have pre-medication or pre-treatment lab requirements, as well as any therapies that specifically require resuscitation equipment to be on hand. So this approach will continue to balance the member and provider experience with cost savings, and the program implemented would be mandatory for new starts only. It will ensure that care is not disrupted for members who have already established a routine for their infusion therapy. And in the future, we'll be scoping that drug list. Lastly, on the next slide, I wanted to touch on emerging cellular and gene therapies. These work to manipulate expressions of genes or alter the biologic properties of living cells to treat or cure rare diseases. As the pipeline grows and gene therapy continues to evolve, the management strategies in this section is critical. An example of such a therapy is Zolgensma. It's provider administered. It's approved to manage a rare degenerative genetic disorder called spinal muscular atrophy. The purchasing price, to note, of Zolgensma is approximately $2.1 million for the one-time infusion. And the clinical trial was conducted on a small patient population of 20 people because this condition is so rare. So we're pursuing the opportunity to establish centers of care excellent models through which the prior authorization process steers recipients of gene therapies to the hospital in which the clinical trial was conducted. This allows the administration of the treatment in the optimal setting with practical experience, thereby delivering high quality of care in treating these patients with rare diseases for which they're being studied. We're beginning to construct and implement this strategy for fully insured groups, and we'll certainly keep the board apprised. And that will wrap up the quick updates on the progress that we continue to make under pharmacy and will continue in the years forward. Are there any questions? I know we're short on time.
I think we're good. Okay.
Thank you then.
Thank you, Katie.
There's a hand raised.
There is a hand raised. John in.
See it.
Hey, just a quick question as we transition to the next part of the meeting. I just want to make sure that we still have a quorum, since a few people have had to leave.
I believe we do.
Yeah, we
I
do.
think we just lost 3.
Yeah, so we're still good.
Okay, cool.
All right, before we move to Kaiser, let's take a 10-minute break. See you back at 2:45.
What are you munching on, Jeff?
Dry roasted almonds.
Mm.
Healthy.
I just finished off a big thing of cashews from Costco. I'm a cashew fiend. Yeah, yeah.
Costco.
Kirkland nuts. All right.
You don't have a ponytail now, do you?
Almost. About maybe by March, I will.
You're really looking like a techie these days.
Yeah, with my hoodie and excited. I have not left the house other than Freddie's probably in 5 days.
To an automatic voice message system.
Wow, what happened?
I don't know.
587 is not available. At the tone,
I don't know. That's somebody with a cell phone.
Okay. Well, I'll mute this while I'm munching, but let me call us back to order.
Do you guys see the presentation?
We do.
Yes.
Okay, thank you.
Let's go ahead and get started.
Great. Well, we're happy to present a presentation on affordability and how we plan to maintain the mandated 3.4% cost increases over time, and kind of also focusing on how COVID will impact that and some of the innovations from COVID can actually help us achieve that. And all of that's embedded within our model of care, which is unique and really is our main leverage in terms of being able to provide both great care and cost-effective care. Well, today I'll be presenting with Sapari Sturdivant, who you all know, and Jennifer Stacy, and myself. With that, I think I will turn that over to Sapari to take us through this initial slide.
Yes, thank you, Dr. Bachman. I first wanted to acknowledge for all of us 2020. 2020 brought a lot of sadness and fear and frustrations, and with the pandemic that hit us earlier than in the year. But I also wanted to remind us that, in addition to the pandemic, which caused, our world to shift, we had employees working from home. We had our care delivery system, our providers shifting where they work to conserve PPEs. And then once we thought that, the pandemic was kind of under control, with respect to servicing, then the wildfires hit. And the wildfires then created a lot of smoke. And the smoke then led to one of our hospitals, our Sunnyside hospitals, having to be evacuated in preparation to make sure that, if we had to evacuate the system in total, that we would be prepared to do so. And then, we all hoped for rain to hit, and it did hit. But once the rain did hit, then it caused flooding in some of our facilities. So 2020, we are glad that it's over. However, it does definitely continue into 2021 now that we have a vaccine. So we will definitely talk about some of that later on in the presentation. So I wanted to address that, if you want to find the positive that came out of this pandemic or is coming out of the pandemic, for us at Kaiser Permanente, definitely it helped to speed up our processes with implementing telehealth services. With telehealth for Kaiser Permanente, for us, it's not just telehealth with our primary care physician, but it actually expands to our other provider specialties, including behavioral health, which was big during this time frame in having access to providers virtually, and also with physical therapy and our specialty care. In addition to that, our mail order capacity definitely expanded with COVID, as people were less frequently coming into our offices, and we were promoting, definitely wanted to keep people to adhere to their medications, and heavily promoted mail order, which you will see in the slides coming up, that utilization definitely has gone up during this time period. And then in addition, we have an e-visit out on our pp.org website that kind of helped to address additional access points with people with concerns of COVID. We flex that system to accommodate for COVID-related questions. We also flex the system to accommodate for behavioral health issues. And also wanted to address testing and care that we provided to our members were covered at no cost. With this pandemic, as Kaiser Permanente in total, we have over 12 million members. So it was nice to funnel a lot of the issues to our national command center to make sure that we are ready to care for members in the long run. And then wanted to also mention that with this pandemic, we redeployed our staff and resources to support those areas that needed it most. Even myself in the administrative area was redeployed or have been redeployed to help out in our clinics with assisting greeting. I also assisted with flu shot clinics, and a quick story there with flu shot clinics. When we first opened, it was great. The demand was extremely high. So high that at the clinic that I worked in, we actually had to shut it down because of traffic issues. There were a lot of people who wanted to get it, which again is a great thing, but it helped us to learn about drive-through clinics and how to set it up. So, definitely set us up for the future with COVID vaccines. And then wanted to mention that along the way, we continue to provide communications to our groups, to our consultants, to our members to make sure that they're well updated on what's going on, what facilities are open, and what services we are providing. We've done this through webinars, through direct communications to our members. If you are a Kaiser member, you will obviously notice that you get emails from us regularly to tell you about what's happening. And we issued playbooks and school-specific return to school playbooks to help our schools to be prepared to when they go back, and provided resources that they could link to support those efforts. And in addition, lastly, I just wanted to mention that with the vaccine that is being out, a lot of people obviously are very interested and curious about what's happening with that. So we've developed a vaccine hotline to provide the most up-to-date information as to who is eligible for the different phases, and just again to help alleviate some of the questions that they may have. The next slide. So with respect to telehealth, as you know, again, it has driven our organization to move quickly. And what we have found is, I think what we all know is telehealth definitely helps to reduce the cost of care. Access virtually is definitely less expensive than the in-clinic. And we are seeing a lot of members really appreciating that virtual care aspect. And in addition to the cost saving piece, I do want to mention that telehealth is also breaking barriers. It is expanding access to care. It is also eliminating that burden of travel to get to the clinics for care. And because of, we were able to do a survey for our 12 million plus members, those who receive telehealth care. And it showed that, for our first time users, a lot of them are newer to the system, but as you can see from the percentages reflected below, 21% of that are our senior population, which is pretty remarkable, first time telehealth users. 13% of those are Hispanic, 16% Asian, and then 13% are people with 25% or $25,000 to $50,000 income per year. So definitely, again, kind of breaking the barriers for our underserved population and for those populations that, that it's harder for them to get to the clinics. And next slide. So telehealth, just wanted to quickly reference that telehealth at Kaiser Permanente is a little bit different in that, in addition to just the primary care provider visits, we also have, of course, the clinical advice line, which is open 24/7. We have the video visits, mobile apps, our phone appointments, our emails, our online self-care, online physical therapy, and more to come on remote patient monitoring, which we continue to grow. And next slide. So I wanted to share OEBB specific telehealth utilization, just so you can see that, even though our face-to-face volume has definitely declined through this pandemic, that we have been able to fill most of the needs through telehealth services. The blue bar that you see on the screen reflects the face-to-face visits. The green bar reflects our telehealth via phone. The orange bar, if you can see that, reflects our e-visit counts, and then the red bars reflect our video counts. And so as you look at OEBB's data as compared to our book of business, OEBB tends to have a little bit slightly higher utilization for telehealth than our book of business. For October, OEBB's telehealth utilization was at 33.8% versus our book of business at 31.3%. So definitely being utilized by our OEBB community. Any questions before I turn it over to Dr. Bachman to continue? Okay, thank you. Dr. Bachman? Oh, you're on
Thank you,
mute.
Sapari. Got it. Thank you, Sapari, for that. And I'm talking about cost containment, and kind of to piggyback on what Jenny was talking about earlier. When we think about reducing costs, we're thinking about lowering the unit costs of services, or we're thinking reducing the number of services or number of high value services, or reducing the low value services and increasing the high value services. And really, there's hundreds, if not thousands, of these that we do and we're implementing and we're working on and we're improving, and we're just going to focus on a few today in the context of this conversation. I think current estimates about 25% of healthcare spending is considered waste, and a significant fraction of that can be reduced, which could reduce the bottom line of healthcare costs without reducing outcomes or service. Some of those kind of things that might be considered waste would be excess unit costs, duplicative services, services where you see unnecessary variation, low value care, reducing complications. Any kind of a surgery complication would be considered waste, and then decreasing administrative costs and unnecessary administrative complexity. So I'll go through just a few examples that have really sort of come to light during COVID and have been put in for different reasons, including cost savings. So one of those was virtual interpreter services. And that's something we were able to shift that during COVID, since more of our care was going on online with video and with phone calls. So how do we integrate our excellent interpretive services into those visits? By doing that, they had decreased waste because of the number of it's a less expensive way to provide that. There's a wider number of interpreters that could be used because there's no geographic considerations, and it decreases the cost when a patient no-shows for the appointment. So that's been over $2 million of savings just with that. Also,
Dr. Bachman.
Yes.
And are these numbers system-wide or OEBB specific?
This is system-wide.
Thank you.
So, also, administrative costs have reduced as well, with things like decreasing discretionary travel, and then costs of running some of our facilities now that much is being done from employees' homes. So other cost containment initiatives include something with surgical processes. There's actually when we looked at it, there's large variation in the costs per case for surgical and procedural things. And that's really just goes on to sort of how doctors were trained, what they're comfortable with. But as an organized medical group, we can definitely have some standards, which leads to safety by decreasing the number of parts and tools and kits that we need. Surgeons can become experts on one for a department or one for a specific type of surgery, which then lowers the cost of providing that. In our ambulatory surgery settings, we're doing more and more cases on an outpatient basis. The majority of hip and knee replacements currently, and OEBB does an outpatient basis, and we're moving towards a large variety of cases that are being done as in the outpatient setting, which is less labor intensive and safer. We do have to make plans for home recovery. Another example of a reduced cost per service is using our Brookside program, which is an outpatient residential program that we can do fairly complex behavioral health issues there that would otherwise require inpatient substance abuse or mental health programs. Another couple programs that we can do on is on the next slide. Actually, actually, before we get to pharmacy, two other programs that we're doing. One relates to OBGYN, and we're providing for members that have low risk obstetric cases. We're providing a take-home kit to allow someone to do home monitoring of their obstetric care. So that would include a scale, a measuring tape, a blood pressure cuff, and then frequent video check-ins with their clinician. That's been a popular program. So we're providing both education and low risk obstetric services to members that qualify for that. Another inpatient utilization reduction program is our KP at Home program. And that relates to basically home hospitalization for certain selected conditions where members can be followed with home health, with home remote monitoring, with daily physician check-ins. We're using that for some of our COVID cases as well. It can be used in members that have excellent home, that are motivated and have conditions that are responsive to this and have good home support. So members who qualify for this are uniformly delighted with the program and be able to manage their what would be a hospitalization really in an at-home setting. Moving on to pharmacy. Sorry, the slides got a little off there, but I'm now on slide 11. One slide back, please. So this is just kind of on the left side there is really how we can manage cost and quality. And we reviewed this with the OEBB board before. Really all the different processes of our pharmacy program, from managing our formulary to our generic supply chain and really optimal rates of generic utilization at 94%. The ways that we can manage specialty drugs by integrating our pharmacy program and our care delivery program by having step care algorithms that our physicians really keep to reliably. Again, that's the best care with the best medicine in the right situation, and then moving to less value medications if a patient doesn't succeed with the first choice medicines. We're a very large player in the pharmacy. We do our purchasing at the national level for our 20 million Kaiser members. We're able to really get the best prices for medications. And finally, mail order utilization is something that we've really succeeded in, and we really are market leading with our mail order utilization, which is something that we saw really go up during COVID to levels that we haven't seen before. Moving on to the next slide. So on the right-hand side there, you can see the mail order utilization pattern, which really went from 44% at baseline in February up to 76% by April. It has come down somewhat since there, as more people are coming into our medical offices to get their care. It's easy enough to go by Kaiser Permanente Pharmacy to pick up a prescription. And so that's a really market-leading mail order utilization, which saves our members money and saves us money with every prescription delivered. On the left side of this slide, you can see some things that we're doing related to COVID, which includes home delivery of medications on the same day for members affected by COVID, getting facility deliveries of prescriptions when somebody is discharged from the hospital directly to their home or to their hospital room prior to delivery. We used curbside delivery during the COVID surge, so members didn't need to come in to our pharmacies, and then the high mail order utilization with an average turnaround time of 2.2 days. Next slide, please. Great, I'll turn this over to Jennifer Stacy now to talk about COVID vaccination, which is certainly a timely topic, and we know we'll be talking more about that in coming months.
Thank you, Dr. Bachman. I thought I'd start as we talk about vaccinations with something you may have seen in the news. President-elect Joe Biden has recently announced that Dr. Bechara Chukar, who is Kaiser Permanente Senior Vice President and Chief Health Officer, is going to serve as the White House COVID-19 vaccine coordinator. So Dr. Bechara will focus on coordinating timely, safe, equitable delivery of the COVID-19 vaccinations for the entire U.S. population, in close partnership with the relevant federal agencies and departments, as well as state and local authorities. What I'd say, this is a big loss for KP, of course, but we are pleased that Dr. Chukar will be supporting our nation in the effort. A little closer to home, while delivery of the vaccine is regulated on a statewide basis, we're also looking at the approach across our footprint. And I know Sapari mentioned the command center, and that's in addition to one of the many work groups that are focused on the effort in the Northwest region. That National COVID Command Center also includes the vaccine work group that engages leaders and clinicians across the entire enterprise to make sure that we have as close to a consolidated, organized, efficient, and always safe approach as we prepare for administration of our members and our communities. As the data becomes available, our infectious disease specialists across KP have been meeting and reviewing the progress of the various vaccine trials. And we've also participated in several trials, which provides us good insight into the distribution challenges that can become important, like for the Pfizer vaccine, as well as an understanding of what to expect from a safety, from a safety point of view. We always look at the data when something is approved. So when we're approved for the emergency use, when the vaccines are approved for emergency use by the Food and Drug Administration, our own disease specialists and clinical experts will review the data as an important safety component. We do this for all vaccines. It doesn't slow the progress, but it does help us be prepared to get those distributed. Finally, what may not be widely understood, because I have been hearing people talk about flu clinics when they're talking about the COVID-19 clinics, is that the COVID-19 vaccine is much more clinically complex than flu shots, and the logistic requirements are significant. So a very important component of our safety approach is our participation in national vaccine monitoring programs and the tracking of any adverse reactions and the data related to the delivery of vaccines. Knowing we're a little short on time, I know cost was mentioned earlier, and we're aligned with other providers and insurers with that. So I'll stop here and check to see, are there any questions around the broader vaccine approach?
Jennifer, my understanding is that as with flu, they're free if you get them at your facility. I'm wondering whether you're anticipating any off-site inoculation for school workers when their level is up.
Yeah.
Any special accommodation because of time constraints of school workers, like a separate lane for drive-through, or anything that would help us get a good inoculation rate amongst the school population?
Yeah, so I'll start with the question about work site. So we are currently, as you mentioned, focused on delivering through our own work sites. And part of that is the safety component, in that, unlike a flu vaccine, we are, there are monitoring requirements. So after a person gets the COVID-19 vaccine, they need to be monitored for at least 15 minutes longer if they have any serious allergies because of some of the side effects that have been seen. So we are not currently doing drive-through type clinics. We are really focused on getting them out most efficiently and safely. That said, we recognize that this is a huge task that we need to take on as part of the community. And so we are looking at different opportunities, how we will be part of the community solution that gets not only our members, but everyone in the community done. So what I would say is, we'll continue to evolve this. We're looking at all options, but right now, as we're trying to get 1A going and get all of our healthcare systems shored up, we're starting in our systems. Dr. Bachman, would you add anything there?
I would just add that the state prioritization is very important to us and to everybody. We've seen when that prioritization is not used that things have gone south in other healthcare systems and other communities. So the best way to get teachers vaccinated quickly would be to get that prioritization moved up or to a place to say, yes, this should happen in a timely fashion to get teachers back to work as soon as possible. And if that happens, we can certainly accommodate that. As long as we have the vaccine supply. I will say right now, our issue isn't the vaccine supply, it's the logistics of getting space and staff to put vaccines in arms.
Johnny and I didn't raise local governments because I don't think any of our members from that group are in their service area. I didn't get you.
And first responders are considered 1A Group 1. So those folks, we're already reaching out to employer groups with first responders to get them scheduled for vaccinations in the very near future.
Thank you.
Dr. Bachman, this is Susan. I had a question. You refer to teachers specifically. Do you mean all school support staff as well? Or
apologies. Yes, that would be anybody working in the school face-to-face with kids.
So we're hearing in some areas that there were so many people that declined from the 1A group that they are moving to educators. Have you heard that?
We have not. Yeah, we haven't seen that, and we've not gotten to that space. There's still many 1As out there in the community, as we understand it, that need to be vaccinated.
But there's definitely a recognition that we do not want vaccination or vaccination spots go to waste to make sure that when there is no shows or there is extra vaccine available or there is a clinic that's not filled, to make sure that we can get that filled as soon as possible. But again, the best thing to do would be to work on the prioritization of educators, and then we can go ahead and do that and move and get people scheduled.
Thank you.
Any other questions there? I'm mindful of the time, Jeff. Do we have a minute more, or should we move to if there's any questions around the approach that's talked about on the next slide? I know people are kind of read ahead.
I'm hoping that we might be able to extend our meeting by 15 minutes.
Okay.
Do any of you board members have a problem with that?
I'm fine with that.
Okay, thank you.
Fine for me.
Move on, Jennifer.
Okay, so, while we're talking about COVID all the time, we are mindful that we must continue to look at how we improve all components of the triple aim. And we know that our integrated model is our best way to do that. So we're continuing to leverage and build. I'll shorten my discussion today and just call out a couple of key items. Obviously, using the integrated medical home model that is based with coordinated care driven by our primary care team is as a key component to this. And our financing delivery model and aligned incentives work with that to place us in the alternative alternative payment model framework at category 4. So currently, internally, those are the KP owned and operated facilities, virtual care programs, care management, and our dental care programs. About 87.76% of the spending fell in that category. And then the external networks are in the lower category 1. We talked a lot today about how we are trying to limit our expenditures to no more than 3.4%. So even outside of OEB, where we know we have the legislative constraints, we know we are focused on improving affordability and effectively managing across the board because we know healthcare needs to be more affordable. Part of that includes not only leveraging those the coordinated model, but also making sure that we deliver culturally competent care so that we can improve the health outcomes of all of our members. And 2020 saw a real focus, and I know we've discussed with this board the need to make sure that equity and diversity and inclusion is included in everything from our workforce to our care delivery to our programs and to our access. And so we're really focused there on a continuing journey to make sure that all of the materials that we provide, all the tools that we have, and all the research-based work that we're doing will address that social, cultural, and language needs of our membership in all of our care settings. So you'll see there that there are, several areas. I know, I'm sorry, if you'll advance to the next slide. I was seeing it advanced, but it didn't look like. Are several areas, and we've talked a good bit about that, but really the focus on access, the social determinants, and making sure that that integrated care leverages every time we wrap around that member to deliver the right care at the right place at the right time is how we'll be ultimately successful in continuing to deliver OEB the highest value care. Any questions?
Okay.
Okay, thank you. We appreciate the time today.
Okay. So our MODA 360 update.
Hi, thank you all for having me. I'll be giving an update on MODA 360 and the work that we've been doing. As you all are probably aware, we implemented MODA 360 on October 1st for all OEB members. And I don't have a lot of time for this update, but I have a whole lot of information that I want to share with you guys. So I'm going to try and go through these slides fairly quickly, but please do stop me if you have any questions. So, as I just said, we implemented MODA 360 on October 1st. And so we wanted to get the word out to members and entities as best we could so they could start utilizing these new services. So for communications, we sent a direct mailer to all of our OEB subscribers the first week in November. And that mailer included flyers on the Health Navigator team, as well as the new point solutions, and just gave some information on how to access the program and how to contact a Health Navigator. And then that day that we sent that mailer out to all of the members, we digitalized that email and that letter and sent it as an email to all of our OEB entities so that they could know what we sent out in case they get any questions, and then also so they could use that information for their own communications with their members. We have information and links about MODA 360 in multiple places. Members can access their services through their member dashboard, through our OEBModaHealth.com website, and OEB has also included links on their own website. We also highlight MODA 360 and some of the features in our WELL quarterly digital newsletter, and we will continue to do so moving through the year. And we've also utilized our wellness advisors, which CEO got an update from our wellness advisor this morning. We've been utilizing them to also help spread the word to entities that they're working with. So next slide. So every time a member calls MODA Health, for a medical or RX question, they get connected to our health navigator team and speak directly to a navigator. And the goal of the health navigators is really to help members navigate through the complex healthcare system and really to take the member out of the middle of any issues. So the health navigators help navigate the member through different issues that they might have so that it can get resolved, so the member's not left in the middle trying to figure out who to call or what the next step is or what to do to try and get their issues resolved. Our health navigators also provide what we call an effortless experience for members. And this is actually a training that our health navigators are participating in. They've already participated in some of these trainings and they'll continue to do that throughout the year as well. And the goal of the effortless experience is to make the interactions easier for members and also for them to anticipate future needs. So if a member reaches out with a question, the health navigator helps the member with that question, but then they're also thinking of other issues that might come up down the road, and they'll help the member resolve those issues as well so that the member doesn't have to call back or make multiple calls to their provider or to the pharmacy, and really just help them resolve issues quicker. And then our health navigators focus on quality over efficiency, so their goal is really to not get off the call quickly. They are not going to win any awards for answering the most phone calls during a day. Their goal and their job is to provide a quality experience for our members and to help resolve their issues. And in a few slides, I have some member testimonials that I think do a really good job of really explaining the health navigator role and how they're helping our members. And our health navigators, their job is really being powered by this new Moda 360 console, and that's really transforming the way that we support our members, and it's transforming the way we provide customer service to our members. So this new console integrates data from throughout the organization into one location, and then it provides actionable information for the health navigator team to use. So it helps the health navigator be able to proactively identify a possible next best action. So examples of some of the things that are included in the console are things like the health navigators can see who the assigned PCP 360 is, if the member's engaged in coordinated care, if the member has utilized that PCP within the last couple of years or within the last couple of months. They can see if they're utilizing a different PCP other than their selected one. It tells them if they've been to the ED recently and if any of those ED visits could have potentially been avoidable. It also displays chronic conditions for the member, and it also provides care alerts. And so these care alerts are alerts that are for preventive services that are included in our OEBB contract and then also in our contracts with our providers. So for example, if a member is past due for receiving a flu shot, the health navigator will be alerted. Or if a member is diabetic and they've missed some of their diabetic screenings, that alert will show. And it'll also show for alerts of like well child visits and wellness exams as well. And another thing that the console does is it shows the health navigator programs that the member is eligible for. And then it'll also show any communications we've sent to the member about that program and if the member has engaged or enrolled in the program. So for example, if the member is a diabetic that qualifies for the Livongo program, the console will notify the member and also tell them if we've sent them an invitation into the program and if that member has enrolled or engaged in the program. And this information, the care alerts and the programs will, the goal is to close care gaps and then also to help get members connected to the programs that are appropriate for them. So next slide. And you know, we're a quarter in now, so I am going to provide an update, but do keep in mind that this is all brand new and there will be much more information that we're able to report on in the future as we move along. But so far, for the first quarter, our health navigators have responded to 17,401 total member calls for medical and RX. And some of the top benefits or some of the top questions they're answering are benefits, claims, primary care providers. They're helping to search for providers and also questions about prior authorizations. And since this is the beginning of a plan year, these tend to be some of the typical questions that we might get. But starting on the next slide, I'll give some insight into how the health navigators are helping with those questions. The health navigators are also, as I just mentioned, they're referring members to other resources, such as programs within our healthcare services department, wellness programs that are offered by OEB and as well as MODA, and our different point solutions. So let's go to the next slide. So this is one member that worked with a health navigator, and they wanted to thank Pam for all of her hard work. Her son had been out of medical supplies and she was having trouble getting the supplier to send them when the health navigator stepped in and, according to the member, took the case on like a bulldog, calling the supplier multiple times and working with healthcare services to make sure they would get to him as soon as possible. And so what this story shows is it's showing how the health navigator is taking the member out of the middle and helping resolve the issue for the member. The health navigator didn't respond to the member saying that he or she needed to respond and reach out to the supplier directly, but rather the health navigator took that and navigated that to the resolution of the issue. Next slide. Another example is Jose. The member said that Jose was a tremendous help and he was both fantastic and awesome. He went through her claims one by one and explained them, called her DME provider with her to help get some things resolved, and really took the time to make sure everything was done right for her. And this is an example of when Jose started working with this member, he realized that there were some issues with the DME provider that needed to get worked out. And so he anticipated future issues. And instead of just having the member call the DME provider themselves, Jose actually called the provider with the member and made sure that everything got resolved. And this really helped the member out because they didn't have to call the DME provider, call MODA back. And really, when I think of it, the member doesn't know all of the questions to ask because they're not doing this every day. But Jose is doing this every day, so he can be much more efficient in helping to resolve issues like this that come up with members. Next slide. Just one last feedback really quick. This member said that Amber was awesome, and she went out of her way to help this member get her medication, which she had been out of for a week. And the member described her as patient, kind, knowledgeable, and provided great customer service. And this is an example, again, of just how the health navigator is really there to help steer that member through the healthcare system instead of having the member try and work with the pharmacy and the provider on their own. The health navigator can really help be that guide. And I see we have a hand up. Did somebody have a question? Maybe
Erica,
not.
this is Reed. Can you hear me okay?
Yes.
Okay. I appreciate this presentation because I was wondering where we were at with the healthcare navigators. And I can just share with you anecdotally that those complaints that your healthcare navigators have been dealing with usually come, to us through our members, and I haven't received nearly as many this year as I have in the past. So that's good news. But I also am wondering, I know that when we talked about putting this program in place, that there was the concept that they would be helping people manage chronic conditions and be able to see some better preventative care with long-term better health outcomes and less, pull on some of those big emergency procedures. Do you anticipate having data that shows the effectiveness of the healthcare navigators in that respect in the future?
Yes, we definitely will in the future. And through the rest of my presentation, I'll be providing some updates on the chronic condition management. But as we move through just with MODA 360 and have more time and more data available, we'll definitely be able to report on some things like that. After 3 months in, I don't have any outcomes to report at this point, no.
Absolutely understood. Yeah, thank you so much.
Yeah, thanks, Reed.
And then
All right.
Erica,
Yes.
if I could follow up with a quick question related to that. So with COVID and limitations on elective procedures and all that, has that made logistical kinds of rollout issues difficult for you guys? We haven't really heard of any complaints like Reed said, so I assume not, but just thought I'd ask.
Yeah, COVID is an interesting beast, and it's made implementing MODA 360 a little bit different just because everybody's virtual. But in terms of members and accessing the elective surgeries and care, it hasn't really been an issue that we've had to deal much with. No.
Thank you.
Mhm. All right, next slide, Rose. All right, so chronic condition management, as Reed said, we are sending targeted outreach to members to engage them in appropriate programs. And the goal of Moto 360, one of the goals is really to increase engagement for members with chronic conditions. And you will be hearing a lot more about this as we move through the plan year as well. I wanted to provide just a couple of updates on a couple of the point solutions that we implemented with Moto 360 this year. Our diabetes management program, Livongo, and then also our behavioral health app, Maru. If you go to the next slide. Before we get started on that, though, I am going to provide a quick update on cirrusmd. This is the telehealth app that we also rolled out with Moto 360, and it's a text-first telehealth solution that can also be escalated into a phone call or a video call. And in the first through December 20th, we've had 559 total OEBB members register for cirrusmd, and that means that they've downloaded the app either on their phone or on their computer, and that they've registered themselves so that they're ready to use the app when they need to. We've had 183 members use cirrusmd so far, with 232 total encounters to this point. After members utilize Cirrus, they are asked to take a survey. So the next few questions are just responses from the survey. And I do want to stress this is just a little bit of data in a short amount of time. So when we report on this in the future, these numbers are going to change. They could change quite significantly, but I just wanted to give you an idea of some of the things that we'll be able to report on with Cirrus. So of the people who responded, 70% said that their issue was resolved with Cirrus. 28% of the people had an in-person follow-up after using Cirrus, and then 2% did a virtual follow-up. And from the members who had an in-person follow-up, 66% of those follow-ups were to a PCP, 17% to an ER, 10% to urgent care, and then 7% to a specialist. And 22% of the members said that they received a prescription from the use of Cirrus, which is a good convenience for a lot of members. And next slide. This is just a map showing where the utilization is happening with Cirrus, and it's a little reverse than what you would expect. The green is actually higher utilization than the red. And what I like to see about this slide is that it's showing that there is utilization throughout the state. And the green over there on the southern Oregon coast, that has been the highest utilization spot since we started looking at this in October when Cirrus started. So it'll be exciting to continue to see members throughout the state, especially over in the eastern Oregon and southern Oregon areas, be able to utilize Cirrus.
Erica?
Yes.
This is, you had 180 members use this service. What do you, when you envision this, when this rolls out and everyone knows about it, what type of numbers do you think you'll see on because this is like, 0.02% of your membership used it. Is it something that, what do you think is the trajectory on this?
Yeah, I think that we're going to continue to see more and more members register and use the solution. If we look at what we were doing with our virtual visits before, we've already blown the utilization out of the water just in these first few months. So I would expect to continue to see more people utilize it. And I also would expect to see that the same people are utilizing it more than once as well. So it'll be really interesting to see how many members continue to utilize.
Right. I'm just looking at the Kaiser data. The smallest of those bars was the e-visit, which is this type. I think is a kind of equivalent to this, maybe, but it'll be. You don't need to comment anymore. I'm fascinated to see how care migrates from the classic, eyeball to eyeball to this new environment where people text and go from there. So I'm again very interested in seeing kind of like a quarterly how this increases over time.
Yes, I'm actually excited to use Cirrus myself. So when I get the opportunity, I will let you know how it goes for myself as well. But yes, Tom, I'm also interested to see how it continues over time.
Thank you.
Mm-hmm. So Maru is our new digital app that we released, and this is a digital app that deals with depression, anxiety, and burnout for members, and it includes a 12-week program that members can engage with via their smartphone. So when members first engage with Maru, they actually come into a care coordination team, and this care coordination team is kind of like a triage place. And so when they're working with the care coordinators, the members can choose to have their results and participation shared and coordinated with their primary care provider. And so when members choose to have this done, then Maru will provide reporting to the PCP at the following intervals. After the initial intake call with a licensed therapist, at 4 weeks and 8 weeks of treatment, and then also at the program completion. And then also if a participant drops out or if their symptoms become escalated and an alternative form of care is more appropriate for them. And so Maru is coordinating with the PCP providers through that whole process. Also, when a member first calls in to the care coordination team, they're triaged, and because the reality is not everybody who connects with Maru is actually going to be a good fit for the program. Sometimes they actually need a different or higher level of care than what Maru would provide. So in those cases, Maru actually refers members to Moda Health's own internal behavioral health department and health team here at Moda. And then our behavioral health team will actually connect that member with their primary care provider or with the appropriate provider for their level of need. And this is something that Maru doesn't do with all of their carrier partners, but it is something that they have worked out to be able to do with Moda. So next slide. So just a quick update on the utilization. So far, we've had 266 members referred to Maru. And again, this is just through December 20th, so we're just getting started with this. We're seeing that most of the members were referred there through the email that we sent out, which included the flyer. So members definitely responded to that. We're also seeing some members being referred to Maru from the health navigators, which is one of their jobs to do as well. And I'm going to have to really apologize on the bottom chart. I copied that and did not update the numbers. And they're important numbers, so I'm just going to give them to you really quick. Of the 266 people who have been referred, one of them was a no-show, meaning they scheduled an appointment with the therapist and they just didn't show up. 3 of them, or 1%, did not complete the program. That means they dropped out in the middle of the program. Currently, we have 112 members, or 42%, who are actively enrolled in the program. And then 151 or 57% are currently in that care coordination phase. So the majority of those members will go on to be enrolled in the program, but then some of them will also be referred back to Moda Health's behavioral health team. And I see that there's a hand up.
Does the Maru program work with youth?
No, it's 18 and over.
All right.
Yes.
And thank you for clarifying the numbers, because when I saw 180 didn't complete the program, I went, holy net.
Yeah,
and of course, I wasn't smart enough to look and see that the exact same numbers up above. So thank you.
Yes, and I'm so sorry about that.
No, that's okay. It's good to have. It's good that it's working.
All right, I see another hand up.
It went away. It was Rose.
Oh, okay. Thank you. Next slide, Rose. And then is there a slide before this? There should be a couple more slides before this. This one right here. Livongo. This is our diabetes management program. And this one's really exciting to talk about. So far, we've invited just under 4,000 OEBB members into the program. And just as a quick reminder, Livongo gives members a smart glucose monitor, as well as unlimited free testing supplies for members who enroll in the program. And then if members have a reading that's out of range, then it'll send an alert to them, their family, as well as their provider. And they'll also receive a call from Livongo after that reading. And then members can also engage with health coaching and a lot of other resources through the app, including nutrition and exercise. So it really helps diabetics be the best possible diabetic that they can be. And so far, of the 4,000 members that we've invited into the program, we've had 561 members enroll. And that's 15% of the members that we've invited so far. And that OEB is actually seeing a higher than average enrollment in Livongo, which we're really excited about. The invitations for Livongo didn't go out until November because we needed to make sure that we had the correct enrollment in OEB because it takes a little while for the enrollment to settle with OEB. So we've been able to enroll 15% of the OEB eligible members in a pretty quick amount of time. So I'm excited to see how this program will continue, and we will continue to reach out to members and engage them as we move along as well.
I will just add that being provided a continuous glucose monitor is a game changer. Firsthand experience.
All right, next slide. I wanted to give you an update on a few enhancements that we'll be rolling out over this next plan year. And a lot of these enhancements are really around bringing Moda 360 to the member. So the first one is an email summary, and this will be starting this month. And it is the console is now set up to allow health navigators to be able to send an email to a member after a conversation. So the way this would look, if, for example, is if a health navigator was working with a member and they had talked to them about Livongo because they're a diabetic, we'd invited them into the program, but they hadn't responded. But the health navigator spoke to them about it. The email would contain a summary of Livongo, and then it would also it would have a link to Livongo that the member could click on. It would take them to our Livongo landing page where they could get more information and also enroll in Livongo. So the email is really an actionable follow-up for the member. So that'll be rolling out this month. Starting in Q2 2021, so here very soon, members are going to be able to chat directly with the navigator. So through their member dashboard, they'll have a little button where they can just click on it and just start a chat with the navigator instead of actually calling in to speak with the navigator. So a little bit more convenience for members. And then also coming in 2021, later on in the year, we'll be providing enhancements in the member dashboard. An example of what this will look like is that we'll have care alerts. So those care alerts that I talked to you about earlier around diabetes screenings that members were hadn't received, or flu shots or other wellness exams. Those alerts will show up in their member dashboard when they log in. The member can click on it for additional information, and then it'll also it'll tell them how they can connect with the health navigator for if they have any questions or would like more information on the alert. So those are all coming up soon. Next slide. We'll also be be really focused actually on social determinants of health throughout this next year. And I know that we've talked to you about this at a previous meeting, but really bringing in the social determinants of health data is going to help give us more of a 360-degree view of the member and not just that clinical patient, because having that information is really going to enable us to be able to see what the member looks like in between office visits, because the diagnosis codes we receive tells us clinically what's going on with a member, but it doesn't tell us anything else that's happening with that member that might contribute to a person's health. And so having more of that information is going to enable us to be able to really apply more focused interventions where we'd be able to address things such as readmission rates, unmanaged chronic diseases, high emergency department use, and just a lot of different things. So we're working on collecting that data right now, and we are bringing it into our enterprise data warehouse. And as we're able to collect more of that data, we will be pulling it into our console, where the health navigators will be able to use that to help connect members to appropriate programs. And these include programs at MODA, at OEB, and then also community-based resources that would be able to assist members as well. So really excited to report more on that as we move along with that work as well. Next slide. And I'm going to actually toss it over to Katie to talk about an exciting program, Sempre.
Yeah, so very quickly wanted to make you aware that MODA has contracted with Sempre Health to identify members taking select cardiovascular and diabetes medications. Eligible members will receive invitations to enroll through direct mail or email. It's very quick to do so. Once enrolled, the members automatically begin receiving discounts at the pharmacy on those select medications, where they usually fill at the pharmacy that they usually fill, which increase the discounts due as they refill on time, ongoing. Each month, members receive a text reminder when it's time to refill, plus the option to submit refills over text. The more they exhibit adherent behaviors, the less they pay for that medication. There is no cost to MODA, there's no cost to OEB. Enrolled members can save on average about 45% per year on their total out-of-pocket costs of these medications, with an average discount of $26 per fill. And of course, that's based on the continuous filling. We know that improved adherence drives downstream medical cost savings, and so we think this program fits very nicely into the 360 solution. It'll start spring of 2021. And with that, I'll throw it back to you, Erica. Thank you.
Thank you, Katie. So that's just another exciting program that we'll be rolling out over this next plan year as part of MODA 360. Next slide. Now I'm going to shift the focus a little bit and talk about some enhancements for the MODA 360 vision for the next plan year. And these are enhancements that we'll be proposing to add to MODA 360. And I'm really excited about this one and have actually asked Dr. Barrichello to come speak to this.
Terrific. Thank you, Erica. And it's really fun, actually. I was thinking about it earlier today. You know, I've presented to the OEB board several times, but it's always in the very narrow lane under Delta Dental. And I'm excited to be here as part of the MODA team and really demonstrating a very significant stride forward in medical dental integration. So the launch of MODA 360 brings, I think, some really exciting opportunities to support our members and further promote the importance of oral health as an integral part of their overall health. So by adding dental to the MODA 360 program, the health navigators and the care management teams will have a fully integrated view of members' health information, and that will help our members in several ways. We'll be able to identify members who have not had a recent dental to help connect them to their provider of record if there's a history of that, or to help establish care with a new provider if that's necessary, or a new dental home. We'll be able to identify lapses in the frequency of preventive dental services to help close gaps of care. And very importantly, and near and dear to some of the things that I feel very passionately about, we're going to be able to integrate oral health education and information for members with chronic medical conditions on the role that oral health plays in their disease management and help connect them to the appropriate resources. And I believe this integrated approach to health management will further improve utilization of preventive dental services and ultimately improve health outcomes. And Erica, I'll let you take it over.
Great. Thank you so much, Dr. Barrichello. Next slide. Thank you, Rose. This is the last thing to talk to you about today with our MODA 360 update. And we will be proposing to use our health navigators in a different sort of a way with an advanced image steerage. And this is an optional steerage opportunity for high-cost advanced imaging. And we would identify prior authorization requests that we get for outpatient advanced imaging at high-cost facilities where there is an alternative low-cost option available for members. And then the health navigators would, they'll get this new report every day of these new prior authorizations that they've received. And the health navigators will actually reach out to these members just to let them know that they could save money by using a lower cost facility, and they will identify the lower cost facility options that are available. And then if the member chooses, the health navigator can also assist the member with setting up the appointment at that other facility. I do want to stress it's completely optional. Members do not need to, members can choose to stay at the facility that the prior authorization request came in, but it's really more of an education for the member to let them know that they could save money. We propose starting this as a pilot to evaluate member behavior with the opportunity for expansion at a future date. So we would like to start with just a couple high cost facilities and start working with and reaching out to members who get the prior authorizations for those facilities, and then look at expanding that to additional facilities after we see how members are responding to the program up to that point. So I know that that was a lot for a MODA 360 update. There's so much to update you on. And we look forward to talking to you more about the proposals for next year, as well as providing updates on MODA 360 all around as we move through the plan year.
Okay, any additional questions for Erica? Okay.
Thank you, guys.
Okay, we are at 3:50 basically. I think we're going to postpone this open enrollment report. To a large extent, you can read this, but we'll have Linda do a recap for us at the next meeting. We are scheduled to have a discussion about social determinants of health with JJ Reed and Sue Reike-Smith, and Sue is called away. Do you two have any objection to moving that to the next meeting?
No objection from me.
That's
Okay.
fine with me if you want to move it. I know I'm super important, but I can wait.
Okay. Reed, you okay with that?
Yeah, completely.
Okay. Well, thank you all for your patience. I think we may have underestimated the amount of content that was available in some of these subject areas, but I think it was important that we cover all of these changes, additions, and so forth that are going on as we get into this plan year. So Rose, do we have any public comment?
No public comment.
Okay.
Yes, we have a quick CL update from Tom.
Oh,
that's right. Tom, I'm sorry. You've been so patient.
Always, Jeff, always. I'm going to go fast.
Okay, thank you.
CL had two presentations this morning, or two topics, presentations from both MODA and Kaiser Permanente. The first one had to do with our plans, efforts around wellness. And during the RFP process, both of the health plans committed funds to do things to promote wellness. And the first ones that presented was Kaiser Permanente. They had committed $750,000 over a 3-year period of time. And the way that they divided that that money up was first to get involved with on-site flu shot clinics. They went on and developed they worked with a group to come up with a brain training process, that app that had categories of around building capacity for thinking, self-regulation, feeling, and emotion. And they also went on and had a grants to be able to, for entities to be able to build workplace wellness spaces. And throughout the, for all of my time on OEB, stress has been such a huge issue. And as Bill Gropp raised at our meeting today, it's only going to intensify as we look at returning to the school, first as in a hybrid and then full time. Again, still within under the shadow of COVID, that our members need to have support in this area. And what was remarkable was how much the health plans, first, again, I just reported what Kaiser Permanente did. What MODA did was had wellness advisors that have integrated themselves into entities to help with these issues, and very supportive of the needs of our members. So it was for me, a very uplifting hour, and but also a pretty poignant one around identifying what the needs are, and that OEBB staff needs to work pretty quickly and closely with our health plan partners to get out to our members, again, reminding them through multiple avenues of what type of services are available to help people during this time of increased stress. Bill, did you want to add anything to that?
No, that's good.
Okay, so just the one issue, the Kaiser Permanente worksite wellness part, they've spent about 100,000 out of 250 that they had planned. So they're looking at another 150 for grants to be able to work on these wellness places, worksite, stress relieving, relaxation, exercise spaces that will help our members. The second part of our conversation was around prevention services. And if you remember, we had a lot of concern that prevention, because of COVID, was going to, the efforts that we've had would be impacted. And we saw that. Kaiser presented their adolescent well child visits, which to be counted as a positive has to be every year. In January of 2020, it was 57%. In November, it dropped to 33%. Childhood immunizations dropped only a little bit. Breast cancer screening dropped a little bit. Cervical cancer dropped a little bit. Colon cancer screening dropped a moderate amount. But all the good news is it looks like for KP that it is almost at a point where it's not dropping anymore, and that the issue is going to be getting through the backlog. For MODA, it was they gave us different information. They looked at it more from a standpoint of utilization. And again, during the second and third, the second quarter of 2020, just, prevention services, except for childhood immunizations, kind of dropped off a cliff. The good news is that it's back up to now what looks to be the 2019 experience. So the other part that is they'll have the same issue around the backlog that built up because of the gap in care that occurred. And we already heard today from Erica how gaps in care is going to be a major focus of their navigators and other interventions with their membership. So that's very encouraging. And they are looking at, MODA's looking at working with their healthcare providers to have this be a focus. So we're going to continue to look at this. We'll probably have another report in June and see how things are going. And hopefully the trend will at least be stable. I asked Dr. Bachman from Kaiser Permanente, his thought was once we are kind of through the pandemic, in other words, we've hit herd immunity and enough people have been vaccinated, it'll probably take another 6 to 9 months work through the backlog, at least in that system, and the hope would be the same in others. So that's the, any other, I think that's the review.
Great, thank you, Tom. Any questions for Tom? Okay, folks. Stay well. Work hard. And
Thank you, Jeff.
I will adjourn the meeting.
Thank you.